Thank you so much, Leslie. Thank you so much. Hi, everyone. My name is Gladys Yinusa, and I am an NIHR Dementia Research Fellow, DEMCON Fellow with Wessex and Beaumont University. I'm really pleased to be presenting on behalf of the cross-disciplinary Tomato Project team. Listed team members at the bottom of this slide, which represent an organization's logo at the top that you can see, just to acknowledge them and to highlight that this has been a collaborative project. So many eyes and hearts have really come together to move this work forward. Just to take a moment to actually clarify, because I get this question a lot. What is tomato? So tomato is an acronym for nutrition and dementia at home. This work has been funded by the NIHR, National Institute for Health and Care Research, through the Research for Patients Benefit program. So we're really grateful to have had this funding to support this work. I will be speaking about supporting eating and drinking well with dementia at home and drawing insight from the Tomato Project. But just before we get started, I just wanted to give an overview in terms of our time together during this session. I will be signposting to some resource as we move along, and I appreciate that this is a mixed audience, so you may or may not have come across this resource. And besides, this is a Malnutrition Awareness Week, so we will be raising, and drawing people's attention to some helpful resources. So, and also to benefit those that might be seeing or listening to this recording afterwards. I will briefly then talk about nutrition, hydration, and aging well in more general, and then I will sort of narrow our discussion to nutrition-related issues, risk of malnutrition in people living with dementia, and the term malnutrition, which we know comprise of both overnutrition and undernutrition. Although for today's session, I will primarily focus on undernutrition. And I'll briefly talk about sort of mealtimes in different contexts and why should we think about adaptation, and then hone into the Tomato Project, sort of how we did it and what we found and some insight from there. All right. So having good food, nutrition, and hydration is essential for everyone's, health and well-being. But it becomes even more important as we age due to changing nutritional needs, particularly for people aged 65 and over. And it raises an important questions around that sort of what does a balanced diet look like for this population group? I have aging parents myself, so I truly appreciate how vital this is. And that's why I've sort of signposted to this Eating, Drinking, and Aging Well resource developed by the British Dietetic Association. The BDA, I think, is a fantastic public health resource that provides a sort of practical guidance, but also because it has a healthy age appropriate messaging around it. And they've sort of drawn on latest evidence around food, nutrition, and hydration and exercise as well. So if you haven't come across this before, please take a look when you do get the slides. And they do have an easy read version as well. So do feel free to signpost as appropriate. But it's the idea around that sort of maintaining health and well-being, which is especially even important for older people with long-term conditions, particularly with dementia. And nutrition and dementia are closely linked. In terms of statistics, we're looking at close to 1 million people in the UK who are estimated to be living with dementia. And this number is projected to rise to about 1.4 million by 2040. And from these figures on your screen, 2/3 of people with dementia live at home and they rely on family, friends, and carers to support with activities of daily living, including eating and drinking. We know that as dementia progresses, eating and drinking can become challenging for some people. And actually, some people might begin to eat more and gain weight due to various reasons, including maybe, forgetting that they may have just eaten. But what we see commonly is those who people who may not be eating well, so undernutrition, and this can happen for various interrelated reasons. This may include confusion about not recognizing what is in front of the food or the drink in front of them, like the man and the image at the bottom. Or just kind of just refusing completely to even eat or engage with the eating time during the meal times, as we see from the image at the bottom of the woman with her hands up. And there are other related factors. Looking at that image, for example, the food options and the food presentation might be playing a critical role there as well. Other factors as well might be the difficulties expressing hunger and thirst. For some people, is the fact that there are perhaps poor mouth care or poorly fitted dentures, changes in food preferences, and people also perhaps experiencing difficulties with chewing and swallowing as well. And these factors put people at risk of unintended weight loss, you know. And so spotting the signs of poor nutrition is actually very, very important. And I think this is something that, I believe we collectively are passionate about as a community. And actually to do something about it, to take action in response, and so I've kind of has signposted to a useful tool that the Malnutrition Task Force has put together, a very helpful video, a more general way of, starting conversations about eating well in later life. I think is a fantastic resource that you can have a look when you get the slides, or check online. And also the nutrition wheel, as well as the patient association nutrition checklist. These tools are very helpful. They help people, whether it's patients, clients, family carers, friends and staff, working within health and social care to identify the potential risk of undernutrition in adults and provide that sort of appropriate signposting for those who may be at risk. This is particularly valuable for me, I think, in terms of my interest in the home care sector, because of how practical it is, using that sort of structured question to spot the signs of poor nutrition. And it's certainly something we have drawn upon in the Tomato Project as well. And so when we start to think about taking action as well, there's also the aspect around using food to meet nutritional needs. So that food-based approach. And this could involve adapting meals, drinks, and snacks by just adding extra amounts of nutrient-dense food to it. And that lends me nicely to, again, that during meal times and the practices around meal times, and how that differs from one care context to another, in ensuring that that support is adequately provided. So maybe one of the key themes that you can see in the image I've pulled up are some positive practices around meal times in different contexts. And obviously the role of social interaction is so important, and particularly important for people living with dementia. But when we start to think about meals and what that looks like from, as you move across different care contexts, whilst there are some similarities, there are also some important contextual differences, and you may start reflecting on your own practice and the way that the way that you provide care as you move from one care setting to another. So looking at the current slide, for example, as you look, I'll be moving from left to right, there are differences, and some of these differences can influence the way and the level of support and how practical some of our guidelines are. For example, in the home care, in the hospital, there is a resource around the mealtime companion volunteers who would go on particularly the older person's wards during meal times to assist patients who needed that extra level of support with their eating and drinking. And then when you go on the sort of the care home setting, you can see residents sometimes sitting together to eat and have tea together. And actually that person-centered lens is important as well. Some people might actually prefer to eat, or might eat better when they eat by themselves. And then when you move to the home care context, there are other levels of nuances that might exist. For example, is a client living alone in terms of living arrangement? Are they living together with family carers, and the role that family carers play? And again, the interactions between family carer, and the home care worker collectively working together. And so context is actually so important in this case. And it's important that we pay attention to what how these guides and helpful suggestions are implemented across these settings. And that lends me nicely to the idea of, why should we adapt? Why adaptation? And what can be adapted? So just so we are on the same page, what does adaptation mean? Adaptation is when an intentional change or when intentional changes are made to an evidence-informed intervention, either proactively or in response to emerging challenges in order to improve the contextual fit within the new setting. There are a wide range of possibilities of what can be adapted. It could be interventions to fit a new population, a new target group. It might be changes in clinical practice guidelines, changes in health and care policies, checklists, or approaches to implementation, for example, or community-based programs. It really can vary. An adaptation entails making various modifications, and there's a body of literature that really consists of frameworks and guidelines and tools that helps us to sort of think carefully on how to document the modifications being made. What we want is to be able to identify and maintain the core components of the original intervention for making those modifications. So modifications could include substitution, removal or addition, or perhaps rephrasing. There are a host of different ways that we can actually capture this. And the idea is that when intervention fit the care context and are perceived as relevant, practical, useful, and effective, they are more likely to be adopted and used over time. And if an intervention has been adapted appropriately, it can lead to more engagement and uptake. And that sort of lends me to the idea around co-adaptation, working together with the people within that sector to ensure that it does meet that contextual fit. Which takes us really nicely into the existing intervention that we drew upon for tomato. This was work done by Professor Jane Murphy and team back in 2016, and you can have a look at the paper that was published in 2017. They were able to produce an output as a result of a care home resource. So the study was undertaken within the care home context, and these were the outputs that came from the work. You can feel free to have a look, but I appreciate that it's been a couple of years now, and it's not it might need some updating as well. So just bear that in mind. But nonetheless, it's been really well received and widely used as well. However, one of the things that the team found was each time they went on dissemination activities, people who came from the home care sector, whilst they found some of the information helpful and important, it wasn't quite the right fit for them. It was very difficult to implement some of the suggestions and the tips that were in the resource. And so they kept asking, what about us? What about a resource with us? It was very evident that there was a need for that. And this sort of was strengthened by the literature and also the PPI work that shaped the development of this project. So Tomato really responds to these needs. And also we know that home care workers often lack training for proactive nutritional assessment, nutritional care management, family carers who are very much involved in the support of their loved one often lack the resources to identify nutritional problems and to prevent malnutrition. So Tomato really responds to that need to have a comprehensive, evidence-based, person-centered nutritional intervention to support people living with dementia at home. And we know that dementia affects people from all backgrounds and all communities, so we sought to recruit providers as well as participants from across the country. So Tomato was conducted in 2 phases. Phase 1 involved adaptation, the Tomato intervention adaptation, and then phase 2 involved intervention testing. I'll spend more time on the phase 1, but I'll share a little bit about what in phase 2 entailed, because there's a golden thread in sort of how we got to the outcome of the resource and where we are with it. In terms of the method, so we were able to work together with different groups and participants to co-adapt the nutrition intervention. We utilized what we call the ADAPT guidance and drew upon the COM-B model. So we did some intervention mapping as well. Was a qualitative approach that we took. So we had semi-structured interviews, which was conducted face-to-face and online with participants. With all the participants, we were able to send them the original Care Home A4 resource. So it was an A4 booklet. Send it to them. Was also wanted to explore participants' experiences of both delivering and receiving home care for people living with dementia at risk or with malnutrition. We also wanted to identify sort of the priority areas in terms of what they would like to see us make changes to and their preferred mode of intervention delivery. And these changes kind of was incorporated iteratively. So just to highlight that. So who did we work with? We were able to recruit 13 participants. So we worked with 3 home care providers from 3 regions in England. We were able to have recruit 2 people living with dementia, 3 family carers, and 8 home care workers. And the home care workers included, people who were senior learning and developmental leads. We also had a tomato PPI group that included people living with dementia, family carer, dyads, family carers, and a care professional working collaboratively with our PPI leads. And then we had the project steering group, which included, sector representative stakeholders as well, who brought their sort of expert knowledge was so valuable and really helped to enrich the work that we did even as we progressed. They met at key stages of the project, and we also had several follow-up consultations as well. And then we had the Project Tomato team. We had 2 workshops and several online meetings, and all the feedback that came from participants, the PPI group and the project steering group all fed into the Tomato project team. Just before I go past this slide, I wanted to acknowledge the fact that the regional representation, as you can see on the right there, where we recruited PPI group was Voice Global platform. It was really helpful for us in achieving that regional and actually as a result cultural representation, which in many ways informed the development, the adaptation of the resource. So we made significant changes in terms of outcome, drawing on all the feedback and consultations with expert nutritionists and dietitians. And also we're able to then draw on the feedback. The key feedback that we had was that people still wanted to have the A4 resource, but actually would have wanted the companion pack, so a more concise and compact resource was what people wanted. And I just want to pause to acknowledge the voice of the family carer who says, and I quote, keep it simple. Let there be simplicity of language and maybe bite-sized information. Also have a one-stop shop where you go and find some of this information. End of quote. And the home care worker stated, and I quote, something that somebody would have in the bag that just gives some tips and some pointers will be great. Okay. And then just really in response to what people wanted, this was one of the key domains across all the different groups. And so we made several key adaptations. We simplified the language. We had more home care specific nutrition tips and how-to guides. We integrated relevant terminologies within the sector and drew upon that sort of having that culturally diverse and home care appropriate images within the resource as well. So in terms of what the intervention entailed, we were able to develop a 2-hour nutrition awareness training for home care workers. This was designed for both face-to-face and online delivery, and it covered the person-centered nutritional care model domains, which was from the original intervention. So it consisted of sort of availability of food and drink, monitoring and care planning, relationship and working together, and that's both for the family carer and the home care worker, given their shared interests in supporting the person living with dementia, but also thinking about how to enhance the mealtime experience and drawing upon activities and thinking about consistency of care, but also where do people draw their information from, saying that there's a lot on the internet. So again, how to access that evidence-based information. And this training was delivered to the home care workers and then we had the prototype resource that was developed. So we had both the A4 detailed guide, but also the companion handy guide, we called them. And this was tested in phase 2 of the project. And just a very brief stop tour on phase 2 entailed. Phase 2 was the feasibility and acceptability study. We adopted a mixed method approach and delivered the home care training, as I said, to the home care workers who then went on to do to implement the intervention. This was tested for over 4 months. So we had key primary and secondary outcomes that we sought to measure. And in terms of a very top level summary, we found that the key facilitator were engagement and buy-in from family carers. So when there was a buy-in from family carers, home care workers were able to do things slightly differently than they would otherwise have done. They were able to sort of make those changes because that engagement was there. The key barrier, you may not be too surprised by this, but the time constraints was the key barrier for home care workers. Again, within this project, all the home care workers that took part were actually able to make changes and documenting within their action logs weekly the changes that they made. However, they all really highlighted the fact that it was time constraints was a key barrier in many ways. And probably this would have been influenced by the groundwork that we did in terms of the relationship building and sort of ensuring that groundwork was done with the home care providers at the beginning of the study. So yes, home care workers were able to make changes, particularly around the area of enhancing the mealtime experience domain, and participants actually found the intervention to be acceptable. Also pleased to say that the participants, both family care diets and home care workers, received the intervention so well. They really had positive comments about it. Just to highlight, the comment by the home care worker in yellow says it was helpful to have something to look at, especially when you've got a really difficult client and are finding different ways to support. The family carer at the top, and I've just read the last part of their comment, and I quote, "It's very helpful even for myself." And this was interesting because oftentimes we say carers should look after themselves because, looking after your well-being is as important as looking after the person that you are providing care for. So it was interesting to see that, the family carer was thinking differently in terms of also how best to support themselves as well. The senior home care worker stated, and I quote, "Overall, people are getting a lot from the resource, and it will be really nice to have that as a widely used tool across all 7 of our businesses." So it was really good to have those positive comments, but we also had some recommendations and some suggestions and things to consider moving forward. So people wanted to see a more culturally adapted resource, and then to draw on that person-centered lens, or need to have an emphasis on that personal preferences as well. So again, going back to the golden string, we were then able to draw on the feedback from participants who took part in phase 2 and further refine the prototype, ensuring that all the key domains were reflected. So we worked together with our PPI group yet again to do the final post-intervention refinement. And so in terms of kind of takeaways for today, I would say, yes, this study demonstrated that it is possible to co-adapt an intervention to a different care setting. It is actually important to bear in mind that that direct, meaningful engagement and collaboration is so important. And then the idea around that research readiness. So, and this is put in it's two ways. It's really for us as researchers, but also as home care providers. To consider, how research ready we are for the sector. I know that compared to the NHS, so in terms of doing research in the NHS and perhaps in the care home care as compared to those two have not had as much attention historically. So considering that research readiness is so important and to think about ways to collaborate effectively together. But also maybe building capacity when it comes to sort of having more dementia and nutrition champions within the sector. And to also consider the fact that, we did in the master project, we did have home care providers who initially wanted to take part. Some workforce related challenges could not move forward with us, as well as, those who perhaps research was relatively a new idea. I think if we have more case studies that highlight the real benefits and the impact of home care providers being involved in research, it would really help with more engagement and hopefully collectively we would help improve practice. For us, this work will help inform future trial, a larger trial. We want to understand and assess the long-term benefits and the effectiveness of the intervention to improve care for people living with dementia, and hopefully to have that sort of more engage with more communities, and particularly those that have historically been underrepresented in clinical trials. So pleased to say the resources have now been launched and you can actually place your order within your practice. It was launched in July of this year, 2025. Feel free when you do have the slides to go on the link, or you can scan the QR code now to download the A4 guide. So it's available as a PDF, but also the print copies are the handy guides. For the yellow one for family carers and friends, and the home care professionals, it's for the blue one. And thanks to our funder again for supporting us to be able to get this to the hands of those who actually need it. And just to say special thanks to all our collaborators and our participants and all the key people who have really helped to champion this work. Really, really pleased to sort of work with them as well and to have received the support that we got. Thank you all for your time and our contact details. If you sort of want to reach out, feel free. We also want to understand how people are using this within their practice. So do feel free to notify when you fill the form, the resource order form, kind of how you want to use this forward. And if you have ideas around how we mobilize this knowledge moving forward, I'll be keen to have more discussion about that afterwards. So thank you very much.